Hello, everyone. Thank you for joining today's session, How Employers Can Reduce Costs on Musculoskeletal Disorders while Improving the Quality of Life and Well-Being of their Employees. This webinar is sponsored by Virtual Physical Therapists, VPT. Virtual Physical Therapists, VTP, is a national provider of telerehabilitation. VPT is disrupting the current way musculoskeletal disorders, MSD, are treated by enabling faster, better, more convenient care at a lower cost. With any smart device and internet access, VPT's application allows access to a clinician anytime, anywhere. VPT's specialist performs a thorough evaluation via a live two-way video to determine the root cause of the problem and then provide an individualized treatment plan to enable a faster return to pain-free activity. All of VPT's clinicians must have a specialty certification in mechanical diagnosis, MDT, to ensure the highest level of care. VPT provided over 14,000 visits during the COVID crisis and was able to assist a return to pain-free function at a fraction of the time, visits, and cost of care. VPT's outcomes were 50% lower compared to traditional care in the workman's compensation and group health public populations, with a high satisfaction level on both the patient and clinician sides. VPT is also a proud winner of the Validation Institute's 2020 Health Award Value for Musculoskeletal Care. I'm Sean Edwards from World Congress and Validation Institute. I will be introducing our webinar today. A couple of announcements before we start. I'd like to explain how we're handling questions. Due to the number of attendees, participant lines are muted. However, if you have a question for our speakers, please do so using the Q&A feature that you see at the bottom of your screen and submit it there. We'll answer all questions we have time to address during our session today. Finally, please feel free to contact our presenters with follow-up questions. And please note the webinar will be recorded. You'll receive an email with a link to the video so that you can view it again. I'd like to introduce our speakers for today. Aideen Turner is the founder and CEO of Virtual Physical Therapists. And Dr. Ray Bowman is the Chief Human Resources Officer and Senior Vice President, Talent and Team Development at Max Health Plan Solutions, a division of MarineMax. And now, without further ado, I'd like to turn things over to Aideen to get us started.
Well, welcome. We are going to start out right away with a poll question. And we're interested to see if you care about saving on your healthcare plan. Would you like to have a significant savings on your healthcare plan or improve the well-being of your employees? Just answer yes or no. The reason this is so important, right now, currently, more people live with chronic pain than cancer, heart disease, and diabetes combined. That's 30% of Americans. And this unprecedented year with COVID, so many more are living with fear and anxiety. We have loss of employment, loss of loved ones. So this agony that so many of us are going through can manifest itself into physical pain. So what is musculoskeletal disorders? These are just the aches and pains that you feel every day, from herniated discs to ankle sprains. If you look at the graph on the right, this shows you the most common self-reported medical conditions. In the middle, we have a small arrow for diabetes. Just under 10% complain about that they have diabetes. The very bottom is musculoskeletal conditions. This is 5 times greater. We hear so much about diabetes, but we don't hear that much about musculoskeletal problems. One of the issues is that we're spending more and more money on musculoskeletal problems. With all our advancements in healthcare, instead of improving, people are becoming more disabled. And the problem is we're providing more and more unnecessary care. In 2002, we spent $98 billion on direct costs for musculoskeletal disorders. And in 2016, we spent $237 billion. In 14 years, that was a 142% increase in direct costs, or at least 10% each year. Again, why are we spending so much more money? What is going on? So if we break down the data and start looking at things a little bit more closely, one of the things I picked out was a common surgery, spinal fusions. Spinal fusions have increased 663% from 1993 to 2011. The reason I picked spinal fusions is because what does the research say about their outcomes. Are they an effective treatment? That's very controversial, and that's a talk for another day. But these are the things we need to look at. During that same time period, the cost of spinal fusions increased by 319%. During the same time, those suffering from back pain became more disabled. We found a 54% increase in disability due to back pain from 1990 to 2015. Again, the same time period, prescriptions for musculoskeletal problems increased 114%. Injections from 2000 to 2014 increased 609%. And MRIs increased just under 12% each and every year. Are these effective? If our disability rate is going up, then we got to relook at these treatments. One of the biggest reasons it's so important is because who's paying the bill? Now, everyone in healthcare, again, we went from 93 billion to 237 billion. So healthcare is doing really well. We're all making more money. More treatments mean more money for providers, insurers, and everyone else that's in the healthcare world. TPAs, nurse case managers, billing reviewers, we're all making some money. But who's paying the bill? The employer and the employee. They're the only ones that this affects negatively. Now, my next question is, for our poll question, do you know how much you spent annually on musculoskeletal treatments and or pain relief? Previously, I was in charge of on-site physical therapy for companies nationally. And the first thing we did when we went to on-site is we took a look at their spend. And most people don't have a clue of how much they're spending. This is very critical. If you want to get, as an employer, if you want to get ahead of your competition, this is the first thing you should look at, how much you are spending on your musculoskeletal conditions. So our current treatments are failing. What can we do about it? Lancet is a journal that had a great series of articles looking at low back pain, because that's the number one musculoskeletal disorder. And what they found was many of our current treatments, our popular treatments, aren't very effective. So they broke down what has poor outcomes and what has some positive outcomes. Our poor outcomes were linked to passive treatments. This is, you need me to get you better. That robs a patient of their control. It's passive. Instead, if we empower that patient and get them actively involved, that's the number one thing associated with a good outcome. So actively involving a patient is the most important thing for a good outcome. The second thing that they found to have a poor effect is the words that we say in the medical field. So for example, dealing with patients, you hear, 20 years ago, my physical therapist or my doctor told me never to lie on my stomach. These things that we tell patients causes fear and anxiety. So for 20 years, they never do these activities. Or the words that we use for diagnosis. Degenerative disc disease. I hear this all the time. Patients come in crying that they have a disease that's going to get worse and worse. When degenerative disc disease is nothing more than arthritis. Anyone over the age of 30 is going to show degenerative disc disease on their MRI. So explaining this to a patient, that this is common, this is just like gray hair on your head, reducing their fear is what is important. The third thing, surgeries and unnecessary radiographs. Now I mentioned the increase of spinal fusions, 663%. And we're not sure if they're effective at all. Are you better off having that procedure? The research is saying no. MRIs is another big one. MRIs are going up almost 12% each year, each and every year. But yet we're not explaining to the patient what that finding means. So I'm 51. The normal MRI on a 51-year-old for back pain without any symptoms, I have an 80% chance of having multiple disc bulges and over 80% chance of having degenerative disc disease. That's normal, but patients aren't told that. Instead, an MRI, when we get an MRI, we're broken. It shows something is wrong. And that puts us down a rabbit hole of increased treatments. The fourth thing that we found was disability payments, our current workers' comp, and our fee-for-service schedules. We need to rethink this. Are we helping people or are we holding them back? Well, the good news, those three things, we can easily change. So the research also showed us what has the best outcomes. The most important thing is early access to proper care. Well, what is proper care? Proper care is number 2 to 5 and something that we can address. So the first thing is a mechanical assessment. And what is a mechanical assessment? Mechanical assessment is just a systematic way of uncovering what is the root cause of pain. So for example, my cell phone. If I take an MRI or a picture of my cell phone, it doesn't tell me if my cell phone works. It might show that my screen is cracked or my cell phone can look in pristine order, but it was dumped in water. It doesn't tell me anything. Only moving the patient can I tell if there's something wrong with that joint. Only using my phone can I tell if something's wrong with my phone. So proper care consists of a mechanical assessment first, and then minimizing passive care, and instead reducing the patient's fear and keeping them active. But currently, as we said, our disability rates are going up. We've got to start all over. And the biggest problem that we have had has been at the very basic thing, and that is the cause of pain and understanding that. We've had the opioid epidemic, but even after that, we still don't understand pain. There's 3 stimuli that trigger our pain receptors: chemical, mechanical, and thermal. Thermal is heat. Musculoskeletal problems are either a result of chemical or mechanical pain. Now, chemical pain is when you hit your thumb with a hammer or that toothache. It's a constant throbbing pain, and it responds from a chemical treatment. So it's a chemical reaction that's causing that feeling of pain. One thing good about it, it has a short duration. It doesn't last long. So we got to think about all our treatments. What is chemical pain and what's not chemical pain? If it has a short duration, if my elbow's been bothering me for a year and now I'm getting my steroid shot, is that chemical pain? It's only supposed to have a short duration. Mechanical pain, on the other hand, example would be bending your finger backwards. So if everybody bends their finger backwards, that really hurts. You go back far enough. What is the best treatment for that? Epidurals have gone up 663%. Should I get an epidural or steroid shot? Massage, injection, painkillers? The most important treatment is to remove the mechanical stress. The pain is mechanical. The treatment is mechanical, not chemical. That's why this is so critical. We have to know what the cause of our pain is to treat it properly. This is probably my most important slide. It's a simple one. 90% of musculoskeletal injuries or pain is mechanical in nature. So the cause is mechanical pain, not chemical. Yet, what is our first treatment? We give a chemical treatment. And so again, what is my first treatment for mechanical pain? It shouldn't be drugs. It shouldn't be injections. It should be changing the mechanics. Yet what do we do? So instead of your finger, I'm going to put my neck in the same thing. My neck has been hurting. It's now hurting for a month. I'm going to go to my doctor. I'm going to get pain medication. Maybe I'll get an x-ray. It's still bothering me. Weeks go by, I go to an orthopedist, I get an MRI. What is the most important treatment? changing the mechanics. Low back, you're hunched over, I can't even straighten up. Going to get an MRI, I'm going to get surgery. What is the most important treatment? Changing those mechanics. Now, Ray, my partner here, has a good example.
I have a great example. Thank you, Aideen. This is a great slide because it portrays perfectly my own experience, and I want to share that with our listeners briefly. A few years ago, before I got in, our company got involved with virtual physical therapy, I hurt my shoulder lifting some boxes in our storeroom. And so I went to my doctor because I hurt my shoulder. I had trouble with the steering wheel and moving it. The doctor said, you need to see a specialist. So my doctor sent me to see an orthopedist. So I met with the orthopedist. The orthopedist said, you need a sonogram and you need an MRI. So then I went and got it. Now remember, all of these are appointments and time out of the office. So I got my sonogram, got my MRI, went back to the orthopedist, and he said, yes, you have a rotator cuff injury. And he showed me the results, and he says it's pretty serious. We need to schedule you for surgery. I said, wow, that's a big deal because shoulder surgery is so painful. Let me think on it. So he said, okay. So I set an appointment for a month later. I went back. He said, you know, if you wait too long, you're going to be sorry. He brought in 2 other doctors during that appointment, literally 2 other doctors on the floor, all 3 telling me I needed to have this surgery right away. I said, isn't there any other option? And they said, well, we can try physical therapy. So I said, let's try that before surgery. So here's my next appointment. I set an appointment to meet with the physical therapy person, and that was an appointment strictly for an assessment. So then they set me up for physical therapy, and I was sharing with Aideen earlier that it was only during the day. There were no night appointments or weekend appointments. So I ended up having to drive. It took a half hour to drive to the appointment, an hour to be there, and a half hour to drive back to work. And while I was there, that hour while I was actually there, it was a large room, and there were 3 or 4 physical therapists and assistants working, and they would move from patient to patient. And so I ended up in that entire hour of physical therapy, I ended up with maybe 10, 15 minutes of the physical therapist working for me. As Aideen goes through the rest of her slides, I want you to, I can attest, that's why I'm here too, but I can attest when Aideen's therapists are with you for your sessions, for your assessment session, for your repeat sessions, there's no one else in the room. You're not sharing their time with anyone else. They're focused completely on you. And that's one of the several benefits of using VPT. So I'll turn it back to you, Aideen. Sorry to interrupt.
I know, that's perfect. So we need to change everything we're doing when it comes to musculoskeletal care. Currently, we go through that long process. We're getting an MRI before we're having conservative care. We're going to a surgeon before we're getting conservative care. We need to flip it. We should have that lower level clinician that specializes in musculoskeletal disorders. Physical therapists spend 7 years studying this. They should be the screener. So they should screen for musculoskeletal problems. And if something's not mechanical, then they get a referral to the physician to have further testing done. And that's what everyone's confused about. How can you tell everything refers to your back, everything refers to your shoulder? How can we tell if it's cancer? How can we tell if it's some inflammatory disorder? The physical therapist can't, but what they can tell if it's mechanical or not. It's very simple. If you have back pain, I need to move it to change, to reproduce it or to change it. If I move the joint and can't reproduce the pain, then that patient needs to get referred to their physician for further testing. So this is how we treat faster, proper care right away. And then if something doesn't add up, if the therapist finds that they're moving the patient, they can't change the symptoms, Now further workup needs to be done. Now they need an MRI. There's tons of research out. You know, I talk about MRIs a lot. I've had many discussions on them. MRIs are fabulous. They show a clear and accurate picture of our internal organs and internal joints. But we have to know and have to explain to the patient what they mean. Patients that get an MRI before physical therapy spend almost $5,000 more on that treatment episode. What we also know is 70% of those with an MRI that shows positive indications that person needs surgery or they have severe acute pain at onset, they recover. Patients recover, even though that MRI says this person absolutely needs surgery, they have impingement on the nerve, but 70% of the time they recover. So we got to rethink what we think these MRIs. If we move the patient, then we can tell what's going on. Is their nerve getting more and more pinched? Can we take that pressure off the nerve? Again, more research out there on physical therapy first by direct access. Going to the PT first helps reduce costs and unnecessary exams and surgeries. Now everyone says, well, the liability. Physical therapy insurance, liability insurance is less than $1,000 a year, or about $1,000 a year. And these are in states that have been doing direct access for over 30 years. The research is already there. Again, the physical therapist's role is to screen. If anything comes up that's not mechanical, they can't treat it, then that gets referred to the physician. There's also, each state has a time frame. Depending on the state, the physical therapist can't just treat forever and ever. They have a very finite limit. Certain states it's for 10 visits, other states it's for 30 days. And that's a great check and balance. If we can't make that person better in that short time frame, 30 days, then they need to go to the physician to see if there is something that we're missing. This is probably one of my favorite research articles and something you've probably never heard of. This was done by Dr. Ron Donaldson, Mark Miller, and Steve, a couple other therapists that I know. Integrated Mechanical Care is a physical therapy practice based out of Tallahassee, Florida. They do on-site for big companies like Michelin Tires and Whole Foods. They took 5,000 cases of just low back pain that they were treating and compared it to community care with the standard of care. And look what their outcomes found. Not only were they able to reduce costs by 50%, but more importantly, look at their utilization. Almost 50% reduction in MRIs, 40% reduction in injections, and this is the key.
Wow.
78% reduction in back surgeries. You want to know why you haven't heard of this article? Because that's going to lose a lot of money. The only people benefiting from this are the employers and the employees. Everybody else, do you think they want that? 78% reduction in surgeries. Amazing. Now, Dr. Donaldson is very well known, very well respected. If you come across him, ask him if it was easy to get this research published. And Chad Gray, who's one of the founders of IMC, was won the validation award for lifelong award a couple years ago. So he's very familiar with the Validation Institute as well. So the critical part, what did IMC do? And what are other people that have these great outcomes that aren't getting published? It's the quality of the healthcare provider. Proper care. Are they giving proper care? Proper care, again, is that mechanical assessment. So we only use clinicians that have that specialty degree. That's critical. We get resumes all day long with great experience, but if they don't have that degree, we don't use them. Because again, that's mechanical assessment that clinician's able to figure out, is this something I can treat or not? Or do I need to refer to a physician? And then after that, they get to the root cause of the problem. And then more importantly, is then empowering that patient, getting them actively involved in their own care. So what do? All we do is use technology so anyone, anywhere has access to that specialty clinician. This is another important research article that most people have not heard about. Over 40% of isolated extremity symptoms come from the spine. And what does that mean? When you just have elbow pain, you just have wrist pain, you just have knee pain, 40% of the time, it's not your knee, it's not your elbow, it's not your wrist, it's your spine. So we need to assess that. The most important thing when someone comes in, even if it's just they have ankle pain, they've sprained their ankle, we clear the spine first. Not an MRI of the ankle, you clear the spine first, especially when it's bilateral. This is critical. So internally, our own research, we had a lot of visits during COVID. We had a lot of diagnoses of shoulder pain. We took a look at those shoulder pain diagnoses. 50%, not 40, 50% our clinicians flipped to cervical, 50% of the time. Now, workers' comp world is, you gotta be politically correct because we do not wanna give a workers' comp patient a spine diagnosis. So we have to, again, treat it all as one. But even under that, so 50% became cervical. And we can easily, once we know the correct problem, it can easily be treated. But if we're treating a shoulder problem with all the right exercises, that's in vain if the problem is their neck. And I have a lot of people, especially in the workers' comp world, they want to know how long is the patient doing their exercises for, so they want to track exercises. And I keep changing, no, we want the correct diagnosis. I don't care about the exercises. Get the correct diagnosis, empower the patient, they're going to get better. But if you don't figure out what that correct diagnosis is, everything's in vain. And it's not the MRI that's going to tell us what that correct diagnosis is. It's moving the patient. So 50% of our shoulder diagnoses became spine. A lot of them were diagnosed with rotator cuff tears, as Dr. Bowman also had. Of those rotator cuff tears, we rarely ever treated a rotator cuff tear. That's a big diagnosis and a misconception. It absolutely shows up in an MRI, but is that the reason for the inability to lift your arm? Is that the reason for pain? Not what we're finding. So it's usually a small joint problem that's very easily treated. But if that patient gets an MRI and they know they have a rotator cuff tear, I always say an MRI, I have to add 8 visits onto my case because now I'm trying to talk the patient off the cliff. So even if they're 100% no symptoms, I spent 8 visits trying to say, yes, your rotator cuff is torn, but you're 100%. Do you have any limitations? So that's critical. We need to screen the spine before an MRI.
Dean, to finish out that, what you just said, or reinforce what you just said, I never had surgery. My shoulder does everything I needed to do. There's no pain and it's perfectly fine. As you and I discussed earlier, many rotator cuff injuries simply heal themselves over time. If you're careful and take your time, they end up healing. So to your point again, of avoiding the pain of surgery, the rehab for surgery, extraordinarily painful, avoiding drugs, avoiding surgery altogether, if we can do it, let's do it. Back to you.
Absolutely. Thank you. And the rotator cuff is one of the most painful surgeries you can have. So I can talk all I want. Bottom line, we need to see outcomes. So what are the outcomes? About 5 years ago, this was our first workers' comp patient under one call. One call is a big PPO for workers' comp. This was the first patient they gave us. This is an actual picture of his truck. He wasn't a 24-year-old using technology. He was actually 62. So not what we expected. 62-year-old seasoned driver, rainy night on the mountain roads, a young kid lost control of his car. And in order to not run over his car, he veered and rolled down a mountain. He was in his truck, hanging upside down, unable to move anything until the jaws of life freed him for over 2.5 hours. So he was stuck in that truck for 2.5 hours, unable to move upside down. I was a treating therapist, and I have no idea what I'm going to get until I start my live session. And before me is a gentleman, salt of the earth, black and blue on top of black and blue from his chest to his knees. In such severe pain, it's now day 5. He can't take a deep breath. He has not slept at all because he can't turn in bed. He can't move because of severe pain. And he could clearly see the shirt the kid was wearing. The fear of almost killing him kept him awake at night. So I was dealing with 2 things, severe pain and fear. Addressing that fear is just as important as reducing that pain. But here before me, the first thing we have to do is this still a fracture? Because therapists, I always say once in your life to every therapist, I used to teach orthopedics, you're going to come across a cervical fracture that the x-ray missed. Because when the x-rays are done really early, it may not show up. So here before me, it looks like, it sounds like he's got a fracture, a rib fracture, something's fractured, and it was just missed. But what would I do in a clinic? You very cautiously start to move them. I started to move them nice and slow, not me moving them. In a clinic, I wouldn't either. When someone has a fracture, you want them to move, because if they don't move, then that's a red flag. But if I can ask them to move and they move slowly and start moving more and more, that's usually just a yellow light that this seems to be okay. So I don't want to passively move them. So he started moving, and lo and behold, he felt better. We moved him a little bit more and more. Under that severe pain that he couldn't take a deep breath was something easy to treat. It was a derangement in his mid-back, a thoracic derangement. He was pain-free in 8 days. But again, the second most important thing though is reducing his fear. So he told me he was petrified. He couldn't, the reason he needed virtual care, petrified to drive. So we walked him through that each and every day, each and every visit. And his goal was just to get back into the truck as soon as possible. And we had to talk to his nurse case manager, because the rules and regulations, you're not back in the truck till you're 100%. You have to be able to drive 8 hours, all these other rules. He wanted to be in as a passenger. He wanted then to be in just for 2 hours. Take those baby steps. We got him back to work way ahead of time. Now, the key to this, and this is under the comp, day 1, we always ask patients, what's it like working there? And the response lets you know when they're going to go back to work. In this case, he said, it's like a family. They all showed up at the hospital. They gave me a gift basket. So my mouth smiled from ear to ear, because I knew he was going back to work early. It had nothing to do with me. Really, it had to do with his employer and how they treated him. So this is just, even with our group health, patients get better if they're in the right environment, a positive environment that reduces fear and anxiety. So that was our first comp case. It turned out to be a good case. But overall, now what do our numbers look like? So we get our numbers from the insurance carriers. That's more important than what I give out. Our average visits for workers' comp given to us from one call and a couple of the insurance companies, I think this is Liberty's, 6.4. 6.4 visits for workers' comp, when the national average is 12 to 18. Believe it or not, this is a tough sell. Not a tough sell to the employers and someone paying the bill. This is a tough sell to everybody else. Why? We're spending $237 billion a year on musculoskeletal problems. If I cut that in half, our economy would crash. If I reduce back surgeries by 78%, that's going to affect a lot of people. If I reduce PT visits in half, that doesn't just affect PT. That affects everyone making money in healthcare, starting with your insurance. Your insurance plan is only making 2%. 2% off $1 million or 2% off of $1 billion. More care leads to more money for everyone. So that's why we're going to the employer. This is what we want to do. We want to see reduced visits. And how do we reduce visits? Early, proper care that empowers a patient. Self-pay. Now this is an easy sell for self-pay because our rates are low. This was an actual patient. A lot of Americans are traveling overseas with this Airbnb. Our young American kids are doing their internet companies in Vietnam for 3 months and then going to Taiwan. This gentleman was in Vietnam, living in Vietnam, so he didn't have access to American healthcare, and they do want American healthcare. He had a herniated disc, symptoms all the way down his leg. What could he do? So he gets in touch with us. One of our therapists evaluated him. Explained to him, we always explain in the simplest terms, everyone knows how to treat a cut on their knuckle. So a herniated disc, just like a cut on your knuckle, how would you treat it? You can see it, overpressure initially. Once it starts to heal, then you start to bend it. Same exact thing. The further down your leg the symptoms go, that's just like bleeding. Bending it causes that. Putting overpressure, closing down on that disc will centralize, bring those symptoms closer to you. Yet at the same time, if the symptoms down the leg are from scar tissue, and an MRI is not going to tell me the difference. Something has symptoms down their leg, scar tissue. So if you have a bad cut on your finger and you left it straight, now you can't bend it because it's scarred down. The treatment's not going to be overpressure. It's going to be stretching it. Well, this gentleman was an active cut in his disc, simply told how to fix it. 2 visits later, 3 weeks, $178. What would our current traditional plan be? Primary doctor, medication, x-ray, MRI, orthopedic. The costs are going to go way up, and so does the time. Our self-pay patients average 2 visits, and our group health patients are averaging about 3.4. Now we want to see a live demo. So I've talked all about this mechanical assessment. How do we actually do it? And I think when you were registering for our webinar, we asked if he was interested. We had a lot of people interested that didn't want to show the videos. I have one patient now, Dixie, and we're so grateful to her. She was willing to show her video. And I'm going to go over a couple things. So the most we're looking for initially is this patient in front of me, do they have symptoms that I can treat? I want to hear that movement recreates their symptoms. Then I get a sigh of relief because I know it's mechanical. And then I need to uncover what is the cause of those mechanical symptoms. So here is and we look at the motion. Now, I want you to see if you can notice it. You're looking for a loss of motion or difficulty moving. And then after we do exercises, does it change? So here's our patient. She had 3 months ago, she fell and hurt her shoulder.
And tightness kind of in the crease of the axillary area right in through here, and then back on the back, like around the shoulder blade area in the back. Definitely they help. The chiropractor and massage both helps. It's just that it doesn't seem to want to resolve to the point where I don't need that. And so I would like to be able to find a way to make this sustainable, that I can keep from having to, always be putting money towards massages.
During the day would bring those symptoms on.
Definitely, if I have to do a lot of data entry on the computer and I'm on that mouse for 2-3 solid hours, doing copy and pasting from one program into another program or whatever, I notice a huge jump in the pain level.
Okay. And when you're symptomatic, when it's really bothering you, is there anything you could do to calm it down? Any positions or movements that feel the best for you?
Well, when I'm sleeping, it often will hinder my sleep. And so if I can put a pillow, like if I'm laying on my side, if I can put a pillow kind of up under it to get this.
All right, Dixie, we're going to start with your neck. The reason being is that 42% of the time at least, isolated extremity symptoms, so just wrist pain, just elbow pain, just shoulder pain, is actually coming from the spine. So we always rule out that spine first, no matter what it is, especially if the symptoms are bilateral. Right now, you just have some shoulder pain with some scapular and upper trap, and that usually indicates neck as well. So that's the first place that we're going to check, and then we're going to go back to your shoulder. But before we do that, I do want you to bring both arms up for me as high as you can go. I just want to take a quick look at that shoulder motion in general. Okay? And come back down. Does it feel different from your right side to your left side, lifting your arm up?
Oh yeah, there's pain that happens right through here when I do that motion.
Okay. Now I'm going to have you go up slowly. I want you to tell me exactly when the pain starts. I want to see where that angle is.
Right here.
And if you go further than that, what happens?
Then Yeah, it actually kind of lets up a little bit if I go higher,
Okay.
but I can't straighten the arm at all very well.
Okay. I'm gonna do one more baseline of your arm. Go out to the side and all the way up. And tell me what happens there.
Again, I feel it here, and I feel it back kind of around, down around back here.
And come back down. All right, I'm going to take a look at your neck next. So I went nice and tall. Sitting there not moving. Do you have any symptoms?
No.
Okay. What I want you to do is drop your chin all the way down to your chest. And come back up. Any discomfort or difficulty with that motion?
Feel it in the mid back, like right in between the shoulder blades, right along either side of the spine.
So it's both equal though. There's not one side more than the other. Okay.
Right.
Our next motion is going to be protraction, bringing your chin all the way out. Great. And relax. Any difficulty with that motion?
No.
Okay. Then the opposite, retraction. You're going to bring your chin into your neck, but looking straight ahead. Don't let your head drop down or look up. Go a little bit further and relax. You're a little bit tight with that motion. Is there any discomfort or difficulty with that?
Just stiffness. It's like it's not very flexible.
I want you to turn as far as you can. First, we're going to go all the way to the right, as far as you can go. Further, further, further. And come back to neutral. Any difficulty with that motion?
No. I mean, it doesn't seem like it wants to go further.
Okay. And now let's go the opposite way. Go to your left. Further, 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 and come back to neutral. Any difficulty with that motion?
No.
Okay. Did it feel a difference between your right and your left?
No, it just seems like there's a stopping point, but otherwise there's not a lot of pain or soreness with that motion.
And now we're going to drop your ear to your shoulder, tuck in a little. Yeah, okay, perfect. And come back up. Any problem with that motion?
Right through here.
Okay.
On this side.
And now tuck in just a little bit and go the opposite way.
Ooh, I heard a crack.
Okay. And come back up straight. Any problem or difficulty with that motion?
Same on the opposite side, right through here.
Okay, were they about even or was one more than the other?
About even.
Okay. Now we're going to tuck in just for good posture. And you're going to look up to the sky as far as you can go. Further, further, further. Great. Tuck back in and come back up to neutral. Perfect. Any problem or difficulty with that motion?
No.
Okay. Now we're going to do what we call repetitive motions. So I'm going to look at one motion over and over again, and then see if there's any effect on your shoulder. What we're going to start with is retraction. Pressure on, pressure off, pressure on, pressure off. 10 times. Good. All right, what I want you to do is lift your arm up again. Tell me exactly when it starts to hurt.
It doesn't hurt as much as it did before.
Okay, and come back down.
Yeah.
Now go out to the side. And tell me about that motion.
Still hurts, probably not as much. Still hurts through here, especially.
Okay. All right, so as you can see, we did something with your neck and your shoulder motion changed. So more than likely it's coming from your neck, but we didn't get that 100% yet. You have some relief. We're going to push on your neck a little bit more this time. And we're actually going to add extension. But usually if your shoulder is involved, it's lower, neck, upper, back. Okay? So I'm going to emphasize extension is going backwards. The most important thing is your head's not out here because you're going to get all your extension up here. We're going to have you retract. I'm actually going to put your hands here and have your neck and upper back go backwards. And we're going to do it 10 times. Okay? Okay, and come back down. Does that feel any different than the time before?
Yeah, that's a little better.
Okay.
Yeah.
All right, so it's definitely your neck now. So we're going to concentrate, and there could be an underlying shoulder problem, but we can't even look into that until we treat your neck. Okay, so we're going to treat your neck first and then see what happens over the next couple of days. If we treat your neck and there's still some residual shoulder problems, then we can take a look at it. Because right now, when you move your shoulder, it hurts. So every shoulder test is positive. But it's a false positive. You're hearing so much about the corona. This is a false positive for your shoulder because your neck is involved. We're going to have you start with your retractions. Okay, this is going to be your exercise 10 times every 2 hours.
Okay.
That's the most important one. And I'm going to send you a video of it. So you don't have to, and I'm going to explain everything. So that's, the most important part is the more you know and more that you understand how to treat your injury, the easier it is. And it's just like a cut. So if you have a cut on your knuckle, you know not to bend it because you can see it. When you bend it, it cracks open. So the first stage of healing is just overpressure. Leave it straight. Don't let it bend. So leave that area alone so it can heal. Less stress on that area. Then after you get a little bit of scar tissue, the next stage is you do want to bend it. Because if you keep it straight forever, it can scar down too much that you'll lose the flexibility.
Right.
So for your shoulder pain, it appears that it's from your head being down in these positions. And you told me what bothered it. Your computer use on your phone, that's the cause. So the fall may have started it, but it hasn't been able to heal well because of those positions. Or the fall was just the straw that broke the camel's back. These positions were really the true cause of it. All right, so the next couple of days, the next 24 hours in particular, I'm going to have you do those exercises I give you 10 times every 2 hours. I'm going to email you and see if you're better, worse, or the same.
Okay.
If you're better, awesome. We're going to continue for 3 more days and I'll do another check-in. I expect you 75% better within 3 days.
Wow.
Okay?
Great.
I'm now going to open it up to questions. And if we have time, we're going to show a second patient. So let's go ahead and start with our questions first.
Great, we've got a bunch of questions in. The first one, what if the back pain began with foot or knee pain and then, by the person walking incorrectly, then they got back pain? Do you virtually provide PT for foot or knee pain? And if so, how's that different?
Sure. So my first question would be the knee and the foot start at first. We clear that spine. So I don't know if that foot and knee pain was actually from the spine or if it was separate, completely separate and isolated to those 2 areas. If it's knee and foot, two areas, I'm thinking leaning towards it's probably the spine to begin with. And then the walking caused, but your back pain just came on later. So yes, our clinicians would screen all that. So the very first thing, if it's just ankle pain, there's still 40% chance it's coming from the spine. So that's what you got to know first. So there are clinicians evaluate you. Then we give you exercises to do. We follow up 24 hours later. Are you better, worse, or the same? If you're better, great, continue with the exercise for 3 more days. If you're worse, it sounds bad, but that means we got to the problem. We're just given the wrong exercise. So that we just have to modify the exercise. So worse means we got the problem. We know what's going on. We're just going the wrong way. No effect. This is what we hate to hear. That means we don't know what's going on. We haven't targeted the problem yet. That needs a more thorough evaluation. So we want to make that person better quickly. And if they're slightly worse, slight modification. So if the person has been walking funny because of an injury, yes, we got to, of course, correct their gait mechanics, and that all can be done virtually. But more than likely, my guess or my money would be on that was a back problem to begin with.
Got it. Another question, how are VTP services different from other digital clinics for back or joint pain?
Sure. And we get asked this question all the time. And everybody out there is focused, again, is on tracking the exercises. There's some great avatar exercise programs that are unbelievable. I mean, we've come a long way. That's not our focus at all, because you're missing the point. The point is the diagnosis. So a rotator cuff tear, you can have an avatar of exercises, but if that could be the diagnosis and that shows up on the MRI. But when I actually evaluate the person, 50% of the time it's their neck. The other 49% of the time, it's a shoulder derangement. So those exercise programs are in vain. The most important thing is proper care. It's the clinician, not a fancy exercise program. The clinician has to be highly skilled to determine the root cause of symptoms. And each and every visit, we focus on reassessing. So our follow-up visit, the first thing I'm going to do with Dixie, for example, we look at her shoulder. Is it better? So I had a follow-up visit with Dixie. Slightly better, but not as good as we wanted it to be. So we emphasize that extension even more. So we know it's better. We got the right, we know what's going on. We just need more pressure. That's all she needed. So we did it a little bit more aggressively, targeting that area. If she wasn't better, we had no effect, complete reevaluation, what's going on? We're missing the mark. If she's worse, then we would just modify the exercise. Follow up by reevaluating every time. Exercise is an afterthought. It's that diagnosis that's critical. And then actively engaging the patient to make sure that they're in control.
So Ideen, I'd like to add to that response that you just made, if I could, and I'm going to approach it from the business standpoint. Most people have never heard of MarineMax, of course, but we're the world's largest retailer for boats and yachts. And I mention that because we have about 2,000 employees right now worldwide. And most of our workers are out in the field. So they're lifting motors and climbing into small spaces to repair electronics and lifting heavy objects on and off yachts and that sort of thing. So we end up having quite a few of musculoskeletal injuries. And prior to getting involved with VPT, one of the things I looked at, being in charge of the healthcare plan at MarineMax, I was looking for the physical therapy intervention. So I actually looked at several offerings out there. And I'll tell you the one thing that sets virtual physical therapy and Ideen and her team apart, in my viewpoint, really two things. One is their advanced standing for mechanical assessment. So these folks are a great place to start in the sense that, you don't have to have a physician's prescription. So that you're not just interfacing with, forgive me, Ideen, for this term, but a normal, regular physical therapist. You're dealing with an advanced standing physical therapist. And then the second piece of that is that they really do focus on the diagnosis piece. We spent, before we brought virtual physical therapy to MarineMax, because I'm very picky as to what we hold out for our employees in our health plan, we actually had VPT Pilot for a year. And during that time, they worked with several of our employees. By the way, just FYI, this is so, I know, call me if you don't believe me, but it was 100% hit rate. I can't, it sounds too good to be true. It is true. And so got a lot of terrific feedback. And so we brought them on as a benefit to our employees not too long ago after a year of looking at them. So I certainly can vouch for the outcomes and the effectiveness of Ideen and her team's interventions.
Thank you.
Thank you, Dr. Bowman. How do workplace or sports injuries fit into the term disorder, since it seems like they're mostly musculoskeletal?
So musculoskeletal and sports injuries are the same thing. So any sports injury affects the joints and the muscles, the ligaments. That's a mechanical problem. So that's exactly what we treat. So we do specialize in sports injuries. And they're the ones that need that to find out exactly what's going on. I'm a former marathon runner, and no matter how much pain runners are in, they continue running. And we need to help them out to figure out what is causing their symptoms. And we look at it mechanically. We reproduce the symptoms, showing it's a lot of times they're not allowing enough healing time, but that's when our specialists can walk them right through. They're a group of people that's really critical, that don't waste their time, find out the root cause of their problem. And you only can determine the root cause by moving them. Sometimes we have them run in front of us. They jog in place, they do squats, they do jumps. We get a lot of, and I always say workers' comp, these are industrial athletes. So they need to be able to go back to running, jumping, doing all kinds of stuff. So when we have an ankle sprain, after we find out the derangement or correct the injury, we do all the plyometrics with them as well in their homes. We do jumps and runs and hops and everything to make sure that they're ready to go back to their sport, their workers' comp sport.
Got it. Question for you, Dr. Bowman. What sort of savings do you anticipate for the healthcare spend at MarineMax?
That's a great question. Let me tell you, going back to the original poll question, I just, for fun for this webinar, I pulled a set of statistics regarding our health plan, because I oversee the health plan at MarineMax. And, you know, I do a lot of research when I look at things. And I went through the spends for hypertension, hyperlipidemia, depression, coronary artery disease, diabetes, asthma, COPD, and congestive heart failure, thinking those were our major expenditures through our health plan. Never dawned on me, shame on me, to look at our musculoskeletal. So when I started to do that, I was blown away. And that's why our poll question, one of our, I guess our second poll question was, not on our first, our second, you know, do you know what you're spending? I didn't know what I was spending at MarineMax for musculoskeletal. And I don't know why, I just didn't. So when I pulled those numbers together and found out that in fact, it's a huge number for us. And so I anticipate probably a 50% savings. So we're talking 6 or 7 figures there for us at MarineMax over the coming year. We certainly, the point here is and that's why I shared with everyone my own experience with the initial, you know, doctor visits and the testing and all of that stuff. A huge amount of money when you talk about 2,000 employees. If we can cut all of those associated costs in half, every business is going to save a tremendous amount of money. And I want to tell you that we anticipate, in answer to that question, we anticipate that our savings are going to be so substantial that we offer it at MarineMax free of charge to our employees. So it doesn't cost them anything for the assessment. It doesn't cost them, the employee, anything for the ongoing therapies. So we have that much faith, especially after that's why I mentioned the year of piloting VPT. So it's substantial.
Got it. Just we're right up against it, but I'd like to squeeze in 2 more quick questions from the audience. Aideen, do you offer free assessments, or is every appointment a paid assessment?
So every appointment is a paid assessment. Now, for the audience here, we are extending that offer to you. If you want an assessment just for marketing to understand exactly what we do that all the time. And it's usually on a Zoom meeting where the decision makers for that employer can observe one of their employees going through our assessment. And then they can talk to that employee. How do you feel the next day? How do you feel a week later? So what our clinicians do, we also do is we follow up by emails. So the emails we don't charge for them. It's just the visits. So that 24 hours later, the clinician sends an email, better, worse, or the same. And we can modify the exercises a little bit via email. But if they need another assessment, that is another visit.
Got it. It should be noted that Dixie did chime in saying she's doing much better after the adjustment to her exercises.
Oh, that's great.
One quick question for you as we wrap up. Aideen, are your PTs all McKenzie or other mechanical training certified?
Only McKenzie. That's the number one part of our quality assurance. Again, we're evaluating virtually. So our clinicians must be well trained in assessing what is mechanical pain versus non-mechanical pain. And the only way to do that is through this training. And they have to have the full certification.
Okay. And we're right up against it in terms of time. Any final thoughts, Aideen or Dr. Bowman, to impart on the audience?
Just do this. Just do it. Be brave. Use your intellect. Just do this. We are tickled at MarineMax with Aideen and her team. So bring this to your companies, please. You'll be glad you did.
Well, thank you, Dr. Bowman. And of course, we are open to doing a free assessment for employers. We'll get it on a Zoom call, have multiple people there. And actually go through our system and see what it's like on that side of it. And then here's our contact information. Thank you.
Have a good day, everyone.
All right, thank you. Thank you for joining us. Thank you to VPT for making our session possible today. Thanks to all of you for logging on. Just a reminder, the webinar has been recorded. You'll receive an email with a link to the video so you can view it again. To access additional webinars or get info on how your organization can speak or sponsor, please visit wcwebed.com. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.